Thank you. Karra Jones is an associate professor of pathology in the Division of Neuropathology at Duke University, with a specific focus on neuromuscular diseases. She received her MD and PhD from the University of Kansas School of Medicine, and she completed her anatomic pathology residency and neuropathology fellowship at UCSD, where she then practiced diagnostic neuropathology, led the neuromuscular pathology service, and assisted in biorepository and biomarker laboratory efforts. She subsequently worked at the University of Iowa, where she expanded her neuromuscular expertise and continued to practice neurosurgical and autopsy neuropathology. At Duke University, Dr. Jones is the section head of muscle and nerve pathology, serves as the medical director of the electron microscopy and immunohistochemistry laboratory, and is the program director for the neuropathology fellowship. Teaching the next generation of pathologists and neuropathologists is a strong passion. Her research interests include inherited muscular dystrophies and myopathies, and she is a consultant for muscular dystrophy gene therapy clinical trials. Dr. Jones is active in the American Association of Neuropathologists, currently serving as the Assistant Secretary Treasurer and Chair of the Education Committee. Welcome, Dr. Jones. Looking forward to your talk.
Thank you so much, Dr. Martinez-Laje. Hi, everyone. I'm happy to see all of your names on the session today and have you here. We are going to talk about some things that hopefully you all will find helpful and relevant today. I do have to disclose that I am a consultant for Astellas Gene Therapies, but the work that I do with them is not relevant for our talk today. And the learning objectives were provided to you earlier on. So today, I really wanted to talk about something that I find to be, pretty amazing in pathology, that there's just such extreme histopathologic variety within a single entity, ranging from mild to moderate to severe, quite frequently, even sometimes within a single gene and pathogenic diagnosis. And so, of course, as pathologists, it's our job to recognize this spectrum of findings and determine the ultimate diagnosis, and that can be extremely challenging. If I asked you all what pictures are here, what these represent, I think everyone here would say it's cake, right? This one over here might be a little bit mild or bland. It doesn't even have any icing. It's just a bundt cake. The one up here on the top maybe is a little bit better. It's got some icing, a nice decoration. And the one over here is even better. It would make any kid or comic book fan super happy on their birthday to have this cake over here, quite decorated. But in the bottom line is we can all look at these and say it's cake. So I thought I would put together a selection of common entities that we all pretty regularly see in our diagnostic practice and show some of the extremes of histopathology in these entities, so we can all come to the final conclusion that it's cake, or at least that cake is in the differential diagnosis, because after all, this is muscle pathology. So we're going to focus on an entity from each of three categories, from toxic, inflammatory, and metabolic. So we'll start out with toxic. And what you can see here is we have two different cases. This first case shows, very little fiber size variation. It would be hard to say, maybe a few 3-to-1 fiber size variation, but not really that significant. Maybe this little atropic fiber over here, but not really significant. Whereas this case over here, number 2, obviously shows a lot of fiber size variation. But even more striking is that we have these rimmed vacuoles that are extensively seen, and a lot of basophilia in these muscle fibers. And even in those that are not obviously containing rimmed vacuoles, we have a lot of stippled basophilia, very chunky stippled basophilia within the sarcoplasm of many, many of these myofibers. Over here, you really don't notice a ton of it. And so we'll talk a little bit now about each of the clinical histories. So the first case is a 57-year-old woman. She has a history of rheumatoid arthritis and progressive bilateral upper and lower extremity weakness. Her medications do include hydroxychloroquine and a statin, and EMG findings were concerning for a myopathic process, but her CK was normal. On the right, we have a 50-year-old woman with a history of lupus. She had hand weakness that began 2 years prior and progressed to generalized weakness requiring a walker for ambulation, with symptomatic bradycardia and heart block. And she also, her medications also included hydroxychloroquine and statin. Her EMG showed diffuse myopathy with membrane irritability, but a normal CK, although aldolase and LDH were elevated. If we look a little bit closer, again, here we can see that really maybe there's a little bit of increased basophilia lining some of these, but it's not really that striking. And here we can see the obvious vacuolization that is very prominent in many of these myofibers, some of which are overtaken by diffuse basophilia, and others where the basophilia is just very punctate and chunky. We did find in this case over here, one myofiber that was more atrophic and basophilic, maybe possibly a vacuole, but not really clear if that is or not. And again, a couple more atrophic fibers. And this one, obviously very vacuolar. So I don't think anyone would have any trouble calling this case a vacuolar myopathy, but case number 1 is much more difficult. When we use our stains, such as modified Gamori trichrome staining, you do notice that there maybe are some increased larger punctate foci here. Usually with modified Gamori trichrome, we really should be seeing a finely granular distribution of mitochondria and lysosomes that stain a little bit darker, but these are a little bit larger than usual, but very, very subtle. And here we don't see a ton of, classic red rimming, but there's a lot of purple staining in these myofibers. And we have these areas that were large and basophilic are also highlighted with our modified Gamori trichrome stain. Now we add in something a little more interesting, that we add some acetylcholinesterase staining. And what you notice is that the case where you really didn't see a whole lot on the other stains on H&E or on Gamori trichrome, we can now highlight some of these punctate foci within the sarcoplasm and even longitudinal foci within the cytoplasm. And these are very suggestive then that there are actually vacuoles present within these myofibers. And here with acetylcholinesterase, we're also seeing some punctate foci within the sarcoplasm, maybe a little bit of lining of some of the larger vacuoles, all suggesting that vacuoles are present. And those vacuoles, when they express acetylcholinesterase, we call them vacuoles with sarcolemmal features. They also can express dystrophin. You can see nice dystrophin positivity here. And on our case number 2, we didn't have acid phosphatase on case 1, but we did have it on case number 2. You can see a very, very significant increase in the amount of acid phosphatase positivity that's red, lining the larger vacuoles, and then also very similar to the same pattern we saw of basophilia in the other myofibers that was more sarcoplasmic and chunky. So we know now that we do have vacuoles in both cases, and at least a subset do have sarcolemmal features. So how do we look for vacuoles? What are some helpful things? I mean, first, it's good to remember what they are. They're membrane-bound foci that contain various cellular components and enzymes. We use the term autophagic vacuoles to really encompass a number of different reasons for having vacuoles. Rimmed vacuoles specifically have basophilic rimming on H&E, and that stains red on Gamori trichrome. Depending on the amount of red in your trichrome, it can look a little different. When I say vacuoles with sarcolemmal features, that means it's a vacuole that's actually outlined with sarcolemmal proteins and even acetylcholinesterase. So dystrophin, spectrin, really any of the dystrophin glycoprotein complex proteins can be positive for that, and then adding in acetylcholinesterase. Stains can really help give you clues to the contents of the vacuoles, but in the end, EM is really the most helpful to see what is within those vacuoles, and sometimes it does matter. But overall, over the years, what I have come to realize is that vacuoles are just really a nonspecific myopathic finding. We can see them in so many different neuromuscular diseases. It can be the clue to the diagnosis, as it is in this case, but it can also be just a part of altered autophagy in other diseases. So usually it is related to altered autophagy or lysosomal function, sometimes even misfolding of proteins, but you can see it in a lot of different things. So how do we recognize them by H&E? We talked about rimmed vacuoles. We talked about some of them are going to be non-rimmed and some of them have sarcolemmal features. And so I thought it was nice to just show some varieties of Vacuoles on H&E, sometimes it can be difficult to distinguish them from freeze artifact, and so you want to make sure that the myofibers adjacent to it aren't showing a lot of obvious freeze artifact, that these look fairly intact when you're interpreting vacuoles. And also vacuoles usually have irregular distribution, whereas freeze artifact is pretty regular, round and regular. A pitfall is similar to the case that we had, number one, that really sometimes vacuoles are so subtle, they only may appear as pinpoint basophilic dots on H&E, or you may need additional stains to pick them out. So here are some stains that can help identify them. We talked about acid phosphatase in our second case, case number 2. Here are some rimmed vacuoles that have nice red rimming on Gomori trichrome staining. Here are 2 different cases that have vacuoles with sarcolemmal features highlighted with acetylcholinesterase. Here's the same with dystrophin. And then TDP43 can actually accumulate, particularly the phospho-TDP43 is really nice to use the phosphorylated form to highlight these abnormal aggregates within vacuoles. Not every vacuole is going to contain TDP43, but many of them will. P62 is something that also is very nice. We had wonderful lectures by Dr. Marta Margetta, and she showed us some great P62 staining in inflammatory myopathies. And this is an example of P62 in an inflammatory myopathy as well. And also, it's really great to really try to train your eye to recognize them by toluidine blue on your EPON sections, because when you get those EPON sections, you can pick out autophagic vacuoles if they're large enough. And they look very similar to this, where you just have open spaces, but it looks like there's something within those spaces, a little bit of more dark staining material within those spaces. That's often what the autophagic vacuoles look like. And so if you see that, that's going to be the slide that you want to pick, the block that you want to pick for pursuing electron microscopy. So a differential diagnosis in this case that we had when we have those vacuoles with sarcolemmal features going from mild to severe, one of the first things we start to think of is the autophagic vacuolar myopathies. That's really where these vacuoles with sarcolemmal features were first described. And so, Danon disease and X-linked myopathy with excessive autophagy were the first 2. Nishino's group in Japan really promoted these as having vacuoles with sarcolemmal features and being the autophagic vacuolar myopathies. Pompe disease you could also include in this as well. And the presence of these vacuoles for Danon disease and X-MIA is due to primary lysosomal dysfunction. One is impaired maturation of the autophagic vacuoles, and one's impaired degradation. But Pompe disease is a lysosomal enzyme deficiency resulting in the same kind of pathology. Although obviously we think of Pompe disease as a glycogen storage disease, but it also has a lot of autophagic vacuoles. So we did actually perform LAMP2 staining in the first case. This is a stain that will help us rule out Danon disease. Obviously, we're dealing with a woman, and Danon disease is X-linked, but it is X-linked in a way that is X-linked dominant. And so we do have some females that can have skeletal muscle weakness with Danon disease. More often it's cardiac disease, but it can appear in Danon disease in women. And so it is something absolutely to consider. And what we see is that LAMP2 staining is intact. And in fact, it's highlighting a lot of autophagic pathology or lysosomal pathology. And so that is telling us that this is not Danon disease. It's a nice way to confirm that. You also want to start thinking about idiopathic inflammatory myopathies. They're very common, and we can see vacuoles with sarcolemmal features. While these are not what is, really promoted in the literature, I definitely have seen vacuoles with sarcolemmal features in all of these cases. And so I think it's something to just keep in the back of your mind, because common things are common. Then there's a whole other list of inherited myopathies with vacuoles. And a lot of these are due to aggregation of abnormal proteins, like in myofibrillar myopathies. Vacuoles are very, very common. Hereditary inclusion body myopathies or multisystem proteinopathies. OPMD and its cousin OPDM, both are characteristically have vacuoles. And then there's a whole other list. And then even things like Becker muscular dystrophy, you can absolutely see autophagic vacuoles and vacuoles of sarcolemmal features in a subset of the muscular dystrophies as just a secondary effect, a secondary alteration in autophagy. And lastly, we have drug-induced myopathies. Chloroquine, hydroxychloroquine can cause a vacuolar myopathy, and colchicine. There are others, but these are the two most common. So anything that we can do? Anyone have any ideas? If you all know me, then you know I'm going to say that maybe we should do EM because I really love EM to help us figure this out. And so I also put in here too, really ultimately, I think the idea behind this is that the vacuoles that we see here really are nonspecific. It doesn't tell us what exactly is going on in this case. We have to do more. So EM is what we're going to attempt next, and we can compare our two cases. And you can see that it's this abnormal material that is myelin-like, and so we call these myeloid bodies, at least that's what they've been classically called. They're within the myofiber. And we also had, in this case, more of a zebra body over here. And then, these aren't really great vacuoles, autophagic vacuoles. They may just be dilated T-tubules. It's not really clear. But, all of this material in itself is very good. All of this myeloid material is really good for autophagic vacuoles. And you can see here all of this junk that's accumulating. These are all great autophagic vacuoles with accumulation of myeloid bodies. So we know there's increased autophagy going on, some alteration in autophagy going on in both of these cases. And then we found the diagnostic finding. Thank you, EM, for saving the day. We have, in fact, curvilinear bodies in both of our cases. And you can see that here. And so what are curvilinear bodies? Well, they actually are somewhat specific. There are many things in muscle pathology that are specific. But if you find curvilinear bodies, then really the only two entities that they are described in is in chloroquine, hydroxychloroquine myotoxicity. That's not the first place it was described, but it's very relevant for our cases here. And then the other situation is when neuronal ceroid lipofuscinoses actually involve the skeletal muscle, which they can. And you can actually see curvilinear bodies in the brain too. And so this is where curvilinear bodies can also be found. Our patients do not appear to have Batten disease or other neuronal ceroid lipofuscinoses. So this really makes a lot of sense that this is all due to hydroxychloroquine myotoxicity in our patients. So chloroquines and really hydroxychloroquine has been what is used most of the time now in our patients, and what we're seeing more often coming to clinical attention because the hydroxychloroquine is being used in treatment of a lot of connective tissue diseases and not just related to malaria like chloroquines were. So, because we have a lot of patients with connective tissue diseases and hydroxychloroquines being used, we're seeing this come obviously to more to attention, not that infrequently. Although there is a pretty low incidence, estimated with a prevalence of only 9.2% and an annual incidence of 1.2% in patients who are on chloroquine or hydroxychloroquine. It's difficult because the onset of weakness can be months or years after starting therapy, and there's no relation to dose. So that makes it difficult. And oftentimes clinicians won't think about it. They'll think, oh, the patient's been on it for so long, they haven't had a problem, and they won't consider that it could be, causing disease. And it causes progressive symmetrical proximal muscle weakness. It can have a peripheral neuropathy, usually pretty mild. And it can also cause cardiac myotoxicity. And if you remember, our second patient actually had pretty severe cardiac disease that was actually related to hydroxychloroquine. CK is usually normal or mildly, maybe moderately elevated. It really depends on the case. Usually there's not a lot of myonecrosis, but there can be. And EMG nerve conduction studies show myopathic changes with fibrillation potentials and myotonic discharges with or without a sensory-motor polyneuropathy, depending if the peripheral nerve is involved. Thankfully, the effects are reversible, although slowly, following the discontinuation of the medication. So how does this all work? Why does hydroxychloroquine and chloroquine cause altered autophagy. And so just as a reminder, we have our autophagosome and our lysosome, and those meet up together to create the autophagolysosome. And the lysosome has its acidophilic contents that then help break down everything into the autophagolysosome or autolysosome. That after the degradation happens, everything gets recycled and exocytosed, and that's our normal, trash can pathway of getting stuff outside the cell. However, chloroquines and hydroxychloroquine, what they do is they actually increase the pH within the lysosome. They go into the lysosome and increase the pH. And so you get deacidification of the lysosome, and then you get a failure of degradation of the contents of the autophagolysosome and accumulation of everything. And when that happens, we characteristically get myeloid bodies, which is really just, autophagic junk, and curvilinear bodies, which are also presumed to be autophagic junk, although it's not really clear why it's so specific for this drug pathway. This is probably one of the largest studies that's been done. It was in 2006, so it would be really nice to have a more updated study now. But they talked about, in this study, they had 119 patients that had undergone anti-malarial treatment for rheumatic diseases. Most of them were on hydroxychloroquine. And out of those, 18.5% had an increase in CK, and they were able to get EMG and muscle biopsy in 15 patients. And at muscle biopsy, by light microscopy, very interestingly, only 3 out of 15 patients had a recognizable vacuolar myopathy. And most of the patients had just normal or very nonspecific myopathic changes by light microscopy. However, by EM, all 15 had curvilinear bodies and or myeloid bodies. So I think this is really important, and it's a really good note for us to make sure that we read our patient's history if we get it, if we can access it, and look at their medication list. And if a chloroquine or hydroxychloroquine is listed, then we need to be definitely doing EM and making sure we look for this possibility. A more recent study actually looked specifically at curvilinear bodies. This is from Australia, and they looked at all the cases that they found curvilinear bodies in, and then looked at whether the patients were on hydroxychloroquine or not. And what they realized is, and then looked at dosage and different details. So they found that detection of curvilinear bodies is unrelated to the cumulative dose of the hydroxychloroquine, which is what we had already presumed, but it was a nice follow-up study to show that. And even it was not related to dose adjusted to body weight or BMI. But interestingly, 70% of patients with curvilinear bodies did have proximal muscle weakness in the absence of pathologic findings for another disease like idiopathic inflammatory myopathy. And 64% of patients with curvilinear bodies had elevated CK. Neither of our patients in these 2 cases I presented had elevated CK. And another thing that they brought up in their paper is that they didn't look for this, but they realized as they were looking at the data that 67% of the patients with curvilinear bodies were taking a combination of hydroxychloroquine and a PPI, which also affects lysosomal function. And so they were wondering if there is maybe a relationship between taking a PPI while you're on hydroxychloroquine, and that could lead to more of a toxicity. And so their future studies need to really be performed to know if that's true or not. So just to show, these examples here, again, very, very mild pathology, hard to even recognize that this is vacuolar. Maybe a little suggestion more of that this is vacuolar here and very clearly over here. And these are some pictures, EM pictures from different cases I've seen. The more you look for this in your patients, the more you're going to find it. So I highly suggest performing EM, and specifically having, when you're scoping or when you have your microscopy technicians scoping for you, have them specifically look for curvilinear bodies with this history. Sometimes zebra bodies can even be seen. So what we're looking for then, our diagnostic clues are going to be vacuoles. If you can't see them by H&E, use your acid phosphatase. They may or may not be red rimmed. Use acetylcholinesterase liberally. Immunostaining, if you've got P62 or LC3, can highlight these. You may or may not have complement deposition. You may or may not have sarcolemmal proteins, because they don't always have vacuoles with sarcolemmal features, but sometimes they do. And then ultrastructurally is going to be your diagnostic finding. Myeloid bodies, this is actually the myeloid body here. Comparing that, I just wanted to show you to inclusion body myositis. We call them myeloid bodies because that is what the literature has historically called them. But really, they're no different than the autophagic pathology that we're seeing in something like IBM. So I just wanted to make that point. Curvilinear bodies are only seen in chloroquines. And then when we talk about colchicine, you can find all of these same findings that we talked about with chloroquines. But with colchicine, interestingly, again, in the literature, it's older literature, they specifically talk about the identification of spheromembranous bodies, but really it's just autophagic pathology. So they just give it a different name, but it looks identical to what we see with other autophagic vacuoles. So here is an example of H&E of colchicine toxicity, and down here, another. Here's an example of Danon disease we talked about, and axemia. So these are two genetic autophagic vacuolar myopathies. And here's an example of a patient with late onset Pompe disease, just finding a very few small vacuoles here. And here's our patient with chloroquine toxicity. So a nice selection just to kind of attune your eye, make sure you look for vacuoles of all different sizes and shapes, and a pretty broad differential. All right, so now we're going to move on to an inflammatory myopathy. And we have 3 cases to look at here. So case number 1 shows fiber size variation, and you can see that this is an acutely necrotic fiber here. This one, there's a few in here that are slightly basophilic, and some of which have increased internalized very large nuclei, suggestive of regeneration. But overall, there is this fiber size variation as being prominent. Doesn't seem like there's really a lot of endomesial fibrosis to suggest significant chronicity in this case. Over here, we again have a pretty intense fiber size variation with a lot of basophilic fibers, a little bit of vacuolization over here and here, possibly over here as well, with more endomesial fibrosis. And some of these atrophic fibers are so small, we're only seeing little bits of remnants of their nuclei in and amongst here. But both of these cases don't really have a very obvious lymphocytic inflammation that you can pick out on H&E. This case over here has a single very necrotic fiber over here, some atrophic fibers here, and then a little smattering of chronic inflammatory cells in the perimesial space over here. So case number 1 is a 70-year-old woman with a 4-month history of progressive proximal muscle weakness. EMG nerve conduction showed chronic myopathic features. Her CK was pretty high, over 6,000, and myositis antibody testing was pending, and they did a biopsy. Does that sound familiar? 61-year-old woman with a 2-month history of progressive proximal muscle weakness associated with interstitial lung disease. Nerve conduction and EMG showed chronic myopathic features, and CK was elevated to over 8,000 with myositis antibody testing pending. And the last is a 66-year-old man who had a 4-month history of progressive proximal muscle weakness. CK was about 5,000. We didn't have electrodiagnostic studies on him, but he was diagnosed with inclusion body myositis and then referred to our institution with a follow-up muscle biopsy because the clinician wasn't convinced, the neurologist wasn't convinced, and they did myositis antibody testing at the same time. And some further images here show, again, more fiber size variation, some vacuolization, some increased basophilia. This one having also vacuolization in these myofibers. More of the endomesial fibrosis is quite prominent, very basophilic in a lot of these fibers. And this one over here shows a little bit of vacuolization as well. So vacuolization is very common in this disease too. If you look for it, fiber size variation is pretty extreme. And when we do Gamori trichrome staining, a slight red rimmed vacuole right there, maybe a little bit of red rimming over here, hard to say. This one wasn't that obvious as far as red rimming, maybe a couple of little areas had suggestion of it. Here's some vacuoles here that are showing up. Overall, there's disrupted, the mitochondria and or lysosomes look altered in these myofibers here, and definitely in this one over here as well. This looks fairly normal with the exception of some of the necrotic fibers being highlighted over here. So this is necrosis and over here. And I failed to mention this is myophagocytosis, active myonecrosis. MHC class 1 in these cases was done either by immunofluorescence or by immunohistochemistry. And so when you look at immunofluorescence staining, we're really looking for the internal positive control of capillary staining, which we have in all three cases, a nice capillary positive control. But when we look at the myofibers, some of the myofibers stain darkly, and we know that necrotic fibers uptake this stain throughout their sarcoplasm. But we also have a little bit of sarcolemmal staining in a small subset of myofibers that are non-necrotic. However, we have some myofibers that don't have any staining whatsoever. So this is how I describe as being patchy positivity. And we have the same thing in this case here, where some of them are entirely negative. Some of them have a little bit of, see here if we can find a good sarcolemmal staining. It's not really that obvious. So mostly negative with maybe a little bit of very, very mild sarcolemmal positivity, maybe some uptake in the necrotic fibers. Again, necrotic fibers will be taking it up pretty strongly, but otherwise it's fairly patchy for all three of these cases, not strong and diffuse. However, when we look at complement C5b9, what we see is these dotted positivity along the sarcolemma of many myofibers. You see this dotting all along, and that's sarcolemmal positivity specific in myofibers. There may be some capillary positivity in here too. Sometimes it gets difficult when you have so much sarcolemmal positivity to identify the capillary positivity, but there probably is some capillary positivity, at least in some of these. But the most striking finding is sarcolemmal positivity. Very big clue to the diagnosis. So we have a smattering of necrotic and regenerating fibers in some of these, some vacuolization being pretty prominent, only a little bit of lymphocytic inflammation, and a lot of complement deposition with patchy MHC class 1. So my fellows would know I would be focusing in on immune-mediated necrotizing myopathy with these patterns. And sure enough, this patient had anti-HMG-CR antibodies. This patient had anti-SRP, and this patient also had anti-HMG-CR. So you can see that, these biopsies are quite different, strikingly different, but they all are immune-mediated necrotizing myopathy. So most often we're going to be able to find antibodies against HMG-CR or SRP in these patients, but there are 30% that are seronegative, and these have a stronger association with cancer. So it's important to keep that in mind, that just because the myositis antibody panels came back and they don't have either of the antibodies, it still could be IMNM. Patients usually have proximal muscle weakness, but sometimes this is seen in patients, and sometimes this is seen in patients who have been exposed to statins, specifically anti-HMG-CR antibodies, but it doesn't have to be, and I'll show you a table coming up. Remember, there can be a cancer association. Some patients have cardiac involvement, and even lung involvement can occur. And the CK is often very high. So that is usually a clue. This is a really great review paper by Tanboon and Nishino, and they talk about all the different, updated classification of inflammatory myopathies. And here is the table from related to immune-mediated necrotizing myopathy. There is an association with some HLA subtypes, and then the things that we talked about, myofiber necrosis and regeneration, sparse inflammation. These are always going to have some positivity for MHC class 1, which is HLA-ABC. They are really going to be negative for MHC class 2. And the key feature here is that consistently there's sarcolemmal deposition of C5b9, and P62 has a particular pattern. So you may be saying, that patient with interstitial lung disease, I was worried more about anti-Jo1, anti-synthetase syndrome associated myositis, but actually there's emerging literature that SRP specifically does have or can have an association with interstitial lung disease, so tuck that away in your mind. And discussing the, exposure to statins and the presence of anti-HMG-CR antibodies, I find it, really fascinating to put this table together to look at different papers. And the percent of patients who had no prior statin exposure that ended up having anti-HMG-CR antibodies. And so what you'll see is that, the study that was done in the USA, this is a while ago now, so it would be nice to have something updated, but in the USA, about 30% of our patients had no prior exposure to statins, but they had HMGCR antibodies, and that just is, greater and greater as you move away from the United States. In Europe, it's about 56%, and in the Asian countries, 2 Asian countries, in China and Japan, it was 86%, and 82% of the patients had no exposure to statins. Is this related to the fact that a larger percentage of Americans are on statins? It's very possible that that's related to this, but it also could be something else. So just keeping it in mind that your patient doesn't have to have that clinical history of statin use to have this disease with HMGCR antibodies. And also this can occur in kids. And so I want to make sure that anyone who sees pediatric muscle biopsies also is aware that this is an entity not to miss in children. So what are some diagnostic clues? We have necrotic fibers with a scattered distribution in different stages of necrosis, myophagocytosis, and regeneration. That's macrophage predominant as far as inflammatory cells go, posse lymphocytic. And then the MHC class 1 sarcolemmal expression. A lot of papers call it diffuse. In my personal experience, I think it's mostly patchy. I wouldn't say diffuse. But I think I have seen one definitive case that was diffuse. So it's not like it can't be. It's just in my experience, it's more often patchy. It may also be related to the way that your stain is worked up. Complement C5b9 staining on the sarcolemma is very key. It doesn't have to be in every myofiber, but I will see it in at least 1 or 2 when I'm considering this diagnosis. Vacuolization is fairly common. There are some papers that say that they are never vacuoles with sarcolemmal features, but I have definitely seen that in my practice. So I think that it's okay to consider all kinds of vacuoles with immune-mediated necrotizing myopathy. And as you can imagine, if we've got vacuoles that can be rimmed and have sarcolemmal features, something that often comes into the differential diagnosis, at least for me, is inclusion body myositis, sporadic inclusion body myositis that can have necrosis and regeneration. And sometimes if patients have been treated with steroids, it may be posse lymphocytic. So that's something that we'll talk about. Endomesial fibrosis is often prominent, but if you catch it early enough, it's not going to be there yet. And enlarged capillaries, such as in this case, can happen as well, but very nonspecific. So as a reminder, the various stages of necrosis and regeneration, we have to be able to recognize all of them. Although there's a really nice paper that talks about, a consensus of different pathologists and their ability to recognize necrosis. And there is very low consensus among expert muscle pathologists in Europe about recognizing necrosis the same way. So, maybe I got it wrong too. But here's the way that I think about necrosis and regeneration for what it's worth. So acute necrosis is very pale fibers, and then the macrophages start coming in, and you can see them munching up the sarcoplasm, and the sarcoplasm just starts to go away because they're doing their job. And then what you're left with is then our satellite cells start to regenerate. We can't really see that on the H&E, but those satellite cells proliferate, and they lead to regeneration of myofibers, which we can characteristically see as basophilia, increased internalized nuclei that are very big with prominent nucleoli. Here are some examples of regenerating fibers over here, very classically. You can even see them very nicely on paraffin sections. And then I would argue that you can see at the later stages of regeneration, the nuclei are not still centrally placed, but the myofibers have slight basophilia. And the reason that I say that I really think this is a later stage of that is because if you use markers like embryonic myosin heavy chain and neonatal myosin heavy chain that show regenerative fibers, that they will be positive. So this is IF from this same section here, showing that these fibers were in fact positive for embryonic myosin heavy chain. So you can use a nice battery of stains. If you have all of these at your disposal, you can, in theory, distinguish between all of these idiopathic inflammatory myopathies using this panel of immunostains. Obviously, we're talking right now about IMNM. And as I mentioned, for me, if IBM has necrosis and regeneration, which it absolutely can, then these two entities become the biggest thing in the differential, and I find hardest to differentiate. So if you have MHC class 2, that can be really helpful because IMNM really should be negative for MHC class 2. Also, C5b9, it's less often sarcolemmal, not that it can't be, but there's less, according to some papers, there's less C5b9 deposition in general in IBM, but I have seen some cases that have a good amount of it. So I think it's still present, but more likely capillary, less often sarcolemmal. So not the best differentiator. And then P62 can also be very helpful, and I'll show you pictures. In IBM, it's more punctate and coarse, and in IMNM, it's more diffuse sarcoplasmic. So this is another really great review of idiopathic inflammatory myopathies. It's more up to date, showing using P62 for more like diffuse sarcoplasmic positivity or versus punctate positivity, more coarse punctate positivity. This is showing the complement deposition. MAC is a complement C5b9. Along the sarcolemma here, some inflammatory cells are highlighted in IBM that really shouldn't be that prominent in IMNM, although you can see them. MHC class 1, I don't think is the best differentiator. In my experience, it's more often diffuse in sporadic IBM and more often patchy in IMNM, but you can have variations on that theme. And then in theory, MHC class 2 should be negative, so that could help. And here are some cases that we've seen where IMNM showing that nice, diffuse sarcolemmal positivity in a subset of the myofibers. And in IBM, this is really vessel positivity that we're seeing. It's not outlining the entire myofiber and stippling it in the same way. So this is a case with a lot of complement deposition, but it is really limited to vessels. And then these images are courtesy of Steve Moore as he was working on P62 of IMNM and some punctate foci with IBM. Okay, and then we're going to finish up with metabolic myopathy cases. And so here are our 3 cases that look quite different again. Case number 1. Hard to find a really good fiber size variation in this image. Everything is, relatively the same size. Really, I wouldn't be able to put 3 of these myofibers into smaller myofibers into any of the larger ones. And there maybe is a slight coarseness to the intramyofibrillar network, but it's not that striking. This case here, we have all of these big holes, but it's not in every myofiber, and it's not evenly distributed like you would expect Friese artifact to be. It's really more irregular and patchy, and often the fibers it's within are slightly basophilic. And that really clean line, that scalloped edge there, suggests that maybe these are lipid droplets. Anytime you see that, you start to think about lipid droplet formation. Maybe a little bit of regeneration in this one as well. And then this case is really severe fiber size variation. And you get the feeling there's a lot of basophilic myofibers and that maybe there's even necrosis and regeneration. It's kind of hard to tell. So our first case is a 68-year-old woman with a 4-year history of progressive neck and proximal limb weakness, worsening vision. She had extraocular muscle, neck, and proximal limb weakness on her exam without ptosis, and they were thinking it might be myasthenia gravis, even though she didn't have ptosis, and it was negative, and then her CK was totally normal. And this woman is 60 years old with a history of restricted eye movements, a 6-month history of rapidly progressive proximal muscle weakness, so rapidly progressive, very different than our 4-year history. And then her exam showed proximal greater than distal muscle weakness with extraocular muscle weakness. Again, a clue to the diagnosis and similar to our first patient. She did have electrodiagnostic studies that showed severe proximal myopathy without fibrillations, and CK was normal. This third patient is a child of 2 years of age with progressive muscle weakness, motor regression, and head lag. Exam showed the proximal limb and axial weakness. She had a brain MRI that was normal, negative family history, EMG nerve conduction was normal, and CK was elevated up to 560, so a little bit above normal. And genetic testing was entirely negative. And so they did a muscle biopsy trying to help solve this case. When we look a little bit farther into case number 1, we can see there are areas of this biopsy that are a little bit concerning in the sense that we have some increased basophilia that's a little bit ragged along the edges of some of these myofibers, suggesting that maybe we will be able to find a ragged red fiber or two in this biopsy. You can see over here too. And the intramyofibrillar network is much more basophilic and prominent than in a normal muscle biopsy. Again, another hint that maybe there's increased mitochondrial aggregation or increased size of mitochondria, although you can't rule out lysosomes as also being basophilic on the H&E. Case number 2, more of the same, these big, scalloped edges that have cleared out space that make you think about lipid, with also extreme basophilia within those myofibers that have the increased possible lipid. And these little droplets here look very, very suspicious for increased lipid here. And even in throughout here, these little foci. And then this one really, this was taken as this probably as a muscular dystrophy in this young girl. There was a significant concern for that. You can see all the endomesial fibrosis and these fibers that look like they're just falling apart. And so this was very concerning to the outside hospital for being muscular dystrophy. We did find something that looks even more convincingly like that's going to be a ragged red fiber when we do our trichrome stain on case number 1. Again, more of the same here, and a little bit of even a suggestion of some regenerating fibers. These are really big nuclei with prominent nucleoli, and they look like they're occurring in fibers that have undergone myonecrosis. So this is even more concerning for necrosis and regeneration with extreme fiber size variation and significant chronic changes. Our trichrome stain, we got a couple of things that maybe look suggestive of a ragged red fiber. Here, there's just some increased red granularity that's pretty irregular in some muscle fibers. Maybe that's a cytoplasmic body. It was hard to tell. And here, too, a little bit of increased red granularity, nothing specific. A little bit better for ragged red fiber here, but again, some non-specific red granularity in these myofibers. We did our dual COX SDH staining. And what you can see is case number 1 was very helpful to identify these blue fibers. So with our dual COX SDH, what happens is that SDH is retained and COX is lost in COX negative fibers. And so those fibers will end up being blue. If they're brown, they have both COX and SDH. And you have to remember that there's mitochondrial heteroplasmy, and mitochondria are not evenly distributed within myofibers. So it's okay if you see a myofiber that has some retained COX in some areas and lost COX in others. That's totally normal. And so you can see that these are blue fibers, are COX negative fibers. This is a definite increase, even in someone who's in their 60s, to have this many COX negative fibers, and it's suspicious. Case number 2 had no COX negative fibers. This is the one with all the increased lipid. In case number 3, it was a big surprise when the stain was done that, oh my goodness, while it was looking like it could be a muscular dystrophy, there are an extreme number of COX negative fibers, suggesting we need to go down a different pathway. We did oil red O in 2 of the cases. You can see the second case, number 2, that we were suspicious for lipid, absolutely has an increased number of lipid droplets. And not only are they increased, but they're enlarged and very irregular. And case number 3 also had an increase in lipid droplets. Moving to electron microscopy, we can see that there are some abnormal aggregates of mitochondria in between the sarcomeres here. And these mitochondria are not that significantly enlarged, and they don't necessarily have specific inclusions within them, but they are aggregating in an abnormal way, leading to that, increased intramyofibrillar appearance of basophilia on H&E. Sorry, I have to apologize. The lipid here is a little bit overexposed, but these are lipid droplets. You have to believe me, these are all lipid droplets. And they are associated with these slightly irregular mitochondria here. You can barely see the mitochondria behind it because they're overtaken by the lipid droplets, but you can see this one looks a little bit odd and maybe some rounded electron dense inclusions within it. And then case number 3 has very, very abnormal enlarged mitochondria. This is an entirely abnormal mitochondrion right here with these really beautiful cristae formations that are highly abnormal. Case number 1, here we have more of the same of this abnormal aggregation, but no paracrystalline inclusions. Maybe a little bit of mitophagy going on over here. And we have a higher power showing the same thing, this abnormal mitochondria in here with lots of abnormal lipid droplets. This one may be here too, slightly abnormal enlarged. And then case number 3, we get even more wild with the way that our mitochondria look. This is a piece of art. And it turns out that these are all mitochondrial myopathies. You know, classically, we think about pathology having ragged red fibers. We think about that we can see on trichrome. We think about COX negative fibers. You can see in this dual COX SDH. We think the ragged red fibers you can see very nicely on H&E as well. And then the mitochondrial inclusions, we think every case should have nice paracrystalline inclusions because that's what we're done and that's what the books say. And so, but there's a huge variability in molecular genetics, and that variability in molecular genetics of mitochondrial myopathies and the, the extreme amount of changes that can happen in mitochondria due to these genetics result in a huge variability in the pathologic findings that we see. So our first patient had a mitochondrial myopathy and her blood testing was negative, but they sent skeletal muscle, a frozen skeletal muscle that identified 15% heteroplasmy for a large-scale pathogenic deletion in mitochondrial DNA, and clinically she was diagnosed with Kern-Sayer syndrome. Case number 2, blood testing revealed the diagnostic finding. It was a heterozygous pathogenic variant in RRM2B, which is a nuclear encoded gene that can have autosomal dominant disease, and she was diagnosed with autosomal dominant progressive external ophthalmoplegia. And case number 3, blood testing also identified the alteration that was compound heterozygous variants. One was pathogenic, one was likely pathogenic in TK2, which is a form of mitochondrial DNA depletion syndrome. So that variability in genetic alterations is related to the fact that mitochondrial myopathies can be due to alterations in nuclear encoded genes, as you saw, or mitochondrial encoded genes. It can be a sequence variant, a deletion, duplication, a depletion. And heteroplasmy is so important because you have to remember that every cell has thousands of copies of mitochondrial DNA, including muscle fibers. And during mitosis, the mitochondria are randomly distributed to the daughter cells. So every cell can have different amounts of abnormal mitochondrial DNA. And this is a nice review about mitochondrial disease in general. And so that you know, the way that these mutant DNA get distributed to daughter cells randomly, you eventually hit up to a biochemical threshold of disease. And so it can be going on for quite a long time until finally a single cell says, I can't take it anymore. There's too many mutant DNA, and now I am suffering from that. And then we may have enough myofibers that show that we'll be getting muscle weakness in our patients. And just as a reminder, SDH is nuclear encoded, COX is mitochondrial encoded, and that's why you know, we can see those changes in the enzymes. So some diagnostic clues and pitfalls, because as we said, the classic findings are great when you've got them, but it can be really hard. So classic ragged red fibers aren't always present. Keep that in mind. COX negative fibers aren't always present. COX negative fibers can be seen in other things. So things like dermatomyositis, here's a bunch of COX negative fibers in the perifascicular region. Or IBM, it's very common, if not always the case, that you have in sporadic IBM COX negative fibers. I use it as a diagnostic clue. Mitochondrial inclusions aren't always present, and lipid accumulation can actually predominate over mitochondrial alterations and be the thing that really catches your eye more so. And the biopsy can appear dystrophic. It really is the case often in those mitochondrial DNA depletion syndromes. That's when I've seen that happen most often, that the biopsies, like, they can be mistaken for a dystrophy. And if you don't use your oxidative enzyme stains, you may go down the wrong path. So use those liberally. And a note about genetic testing, you know, I always like to say something in my reports. You know, mitochondrial DNA testing in blood, usually that's attempted first. It's the easiest, but sometimes our patients aren't going to be diagnosed that way. Not all relevant genetic alterations can be found. So it's important for us as pathologists to know that mitochondrial DNA testing in skeletal muscle can be more sensitive and specific and performed at a lot of labs. So if you can, attempt to retain a portion of snap frozen skeletal muscle tissue from any case you suspect. The companies will tell you that tissue that's embedded in OCT or gum can actually impact the extraction of the DNA that's needed. And so if you have the ability to take a piece and snap, freeze it in liquid nitrogen and just hold it in the freezer for your patient, you'll do them a good service if they need that muscle to be sent off for genetic testing. So help guide our colleagues. Also, I always write a little note in my report that if testing is needed, to let us know, we'll help facilitate that. So overall, take-home points for today's talk is to keep an open mind, use your tools, integrate that clinical history exam. Obviously, we don't get it as often as we'd like, but we try to laboratory values and use multiple pathologic modalities. Don't underestimate the power of EM and some of your histochemical stains, and recognize the extremes so you don't miss something. And I am available to take questions. Yeah.
Thank you. Thank you so much. That was wonderful, Karra. There are a couple of questions already in the chat. I'm going to read them just in case people can't see it. So Dr. Camilo Piragua is asking, is there a definition of chloroquine exposure versus toxicity? Is there a minimum number of curvilinear bodies on EM per area or something alike? Because it could be important that you may need to get off the drug, and then the patients might need to be placed on alternative medications, maybe tested for eye and cardiac toxicity as well.
Yes. Yeah, chloroquine exposure versus toxicity. Really, I guess this is something that we talk about a lot, because once I go looking for curvilinear bodies in a patient with muscle weakness and hydroxychloroquine exposure, I often will find them. And so, these patients usually have a reason they're getting a muscle biopsy. They have muscle weakness, they have a high CK. And so if I see even a curvilinear body in these patients, then I suggest that, that it could be related. But I mean, you're absolutely right, Sandra. Like, we don't, while that one study did suggest that most of those patients had an elevated CK, not all of the time do they. And could it just be that the drug is causing curvilinear bodies to accumulate and the patient's not actually toxic? And I don't have a good answer for that. But if I see them, then I bring up that possibility for sure, even if it's just one curvilinear body. I don't know if that's right.
Yeah, it's challenging. Dr. Punzoni has a couple of questions. The first one is, for cases such as IMNM, it's always great to have clinical serologic confirmation of the entity to support the histologic diagnoses. In many of these cases where there's such a wide variation in histologic presentation, do you use modifiers in your diagnoses, such as active versus inactive, mild, moderate, severe, etc.?
Yes, I do usually try to say mild, moderate, or severe. And I mean, I guess I've never seen a case of that I thought was IM-NM that didn't have at least some active myonecrosis. So I usually will say mild, moderate, or severe. Although, I don't know if anyone else would agree with everyone's mild, moderate, and severe. It's pretty subjective. But yeah, I do usually try to say that. Oftentimes, it's very interesting that SRP cases that I've seen are usually more severe. And I think that's been published in the literature. It's not always the case, but it is frequent enough that people have noted it.
Nice.
And
then
really nice.
I'll paraphrase the last question, so we have time to finish it. Basically, also Dr. Punzoni is asking if in your last case that looked like a dystrophy, but you got the Cox SDH, did that make you go straight into EM and not do the dystrophy panel?
Yeah, so still did the dystrophy panel because unfortunately, very rarely patients can have two things, right? But yeah, I was very, very suspicious that it was a mitochondrial myopathy after that Cox SDH. It actually had come, the case had come like with a request to perform the dystrophy panel because it looked like a dystrophy, and the clinical history could have fit, and so so that was a case where I had just done my additional stains because I always perform Cox SDH, and I also had a little bit of a suspicion because I've seen some TK2 biopsies before, and other mitochondrial DNA depletion syndrome biopsies before. So I was a little bit suspicious anyway, but still performed the dystrophy panel. We don't want to miss a double a double hit. And I think the genetic test was already in progress. I think in that case, I can't quite remember now, actually.
All right. Well, thank you so much again. This was a fantastic tour de force, and I know it's going to
Thanks,
be,
everyone.
you know, a useful reference for everybody for the future.
I hope so. Thank you for having me.
All right. Thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your Path LMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Jones for an excellent presentation. This concludes the session for today.
All right. See you next time.
Bye. Hope to see everyone in June.